Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating the session. Today, we are joined by our main speaker, Dr. Jean Kassia, the Director General of Africa CDC, and we are also joined by the Director of NPHI from DRC, Dr. Dieudonné Mwamba. I will now hand it over to the DG to start the session. Over to you, DG.
Good morning, good afternoon, good evening, all of you. We are taking this call today from Addis Ababa. Yesterday and the day before, I was in Nigeria to assess the performance of the program and to also support the wonderful job done by my brother, Professor Pate, the Minister of Nigeria, and to celebrate the success on the TB agenda. Today, we'll start our press conference with what the world is calling the disease X. First slide, please. You can put it first. Okay. Today, as we know, we have this disease in DRC, particularly in Panzi district, where, second slide, please, where we have around 527, second slide, 527 cases already recorded. And out of the 527 cases, we have almost 42% or 43% under 5 children. And in terms of deaths, we are talking about the 32 deaths coming from health facility level, but we have a number of deaths, around 44. We are saying around because there is ongoing investigation. We want to understand what is going on in DRC. But what is important, I wanted to flag here. If you compare from last week to this week, we have additional 147 cases. If you compare the previous week to last week, it was 111 cases. It means it's a major public health issue in DRC. And I think the Director General of the National Public Health Institute of DRC will provide more information about it. Next slide. Today, DRC and Africa CDC didn't communicate about any pathogen regarding this disease. I want to make it clear. DRC and Africa CDC didn't communicate about any pathogen. The person who's leading all investigation at INRB, it means the National Institute of Biomedical Research in DRC. This is the main referral institute for research and lab. Professor Placide Mbala sent me the message that I'm posting to all of you with his permission. That message was clearly saying that the first samples that they received on the 7th of December, they were poor quality samples. The whole blood and serum were poorly preserved, and some show hemolysis. With that, there was no way for them to conduct the testing and to give us the main reason of this pathogen. And even he said, we don't think that we can obtain any relevant information with that. And a team went back to Panzi, a multidisciplinary team coming from the ministry, from Africa CDC, and from WHO to investigate what's happening in Panzi. But I give you For those who don't know Panzi, when we talk about 700 kilometers, we talk about this road. It takes 3 days to drive from Kinshasa to Panzi. Then we hope by beginning of next week, we'll have the team bringing back some of the samples they are collecting, and we'll communicate. For now, today, we are not giving any indication, any official indication regarding this disease. Next slide, please. Let me talk about Mpox now. We still have this ongoing disease outbreak with 2 countries that moved from controlled stage to active transmission, that are Ghana and Congo. This kind of yo-yo, we see it every week. Countries moving from active transmission to controlled stage, but sometimes coming back. As we are saying every day, we need to reinforce our surveillance. We need to make sure that the lab system is in place everywhere. In terms of statistics, only the week 48, we recorded 3,545 new cases. This one is one of the highest number of cases we have since we started, because our average was between 2,500 to 3,000. But now we have 3,500. It means this outbreak is still moving. And in total, we have 65,000 cases, 65,711. Yes, we are still losing people. I was meeting in DRC last week, a mother who came to meet me talking about his son, 27-year-old, who passed on due to Mpox. He was the only son of this mother. I think when you are facing this kind of challenges, you know that this outbreak is real. Next slide. Currently, the transmission is mostly driven by clade 1B and clade 1A. And you'll see the combination of clade 1A and 1B is in DRC, in the middle. But you'll see on your left, clade 1A, that is not too major, but the clade 1B, in addition to DRC, you have Burundi, Rwanda, where we have more cases. Clade 2 in Africa today is not the prominent one. We don't have so many cases. Even the last week that we had clade 2, it was a week of the 44. Now, our focus is mostly on clade 1B and 1A. Next slide. And this clade 1B, we are reinforcing the cross-border surveillance, because you'll see in number of countries affected, it was mostly due to a movement of people. And we are, as Africa CDC and WHO and all partners, supporting countries. What we are doing, it's unfortunately without the testing capacity, because we don't have rapid tests for Mpox. The surveillance, cross-border surveillance or entry point will be appropriate if we had rapid tests, because we cannot do the PCR at this level. What we are doing mostly is to sensitize people to screen them in terms of temperature, asking if they have some symptoms, but this is the only thing we can do. We hope with the research ongoing, we can have one day the rapid test for Mpox. Next slide. When we talk about the cross-border surveillance, this is an example. Angola affected by DRC, and they notified 9 cases. Now we got the vaccination plan from Angola. I will make sure that next week they will get vaccines to start to vaccinate because Angola is ready today. Next slide. I wanted to discuss with you this issue of testing. Many times when colleagues are asking about, next slide, please. This one will come. Next slide. Yes, many times when we are talking about testing, we don't understand why DRC is standing around 20%. But you see, the testing was moving based on the number of cases. When around week 13, 15, 17, we have low cases. They were testing all of these cases. But now you have more cases, the capacity to test is not appropriate one. This is why Africa CDC is supporting DRC now to activate 463 gen experts, in addition to 7 qPCR machines that we are providing to all to decentralize the lab testing in DRC. Next slide. We have ongoing vaccination in some countries like DRC, Nigeria, and Rwanda. Currently, we are celebrating this success in Rwanda, in DRC, and we are also waiting to see what will be the aggregated result from Nigeria. But things are moving well, and we are glad to see that African countries and African communities are accepting the vaccine. Next slide, please. Talking about vaccines, talking about medicines, talking about diagnostics, we are talking about research. Currently, we have 48 projects ongoing. We are targeting vaccine, we are targeting diagnostics, we are targeting therapeutics, but we are targeting also social behavior. And this is the first time to see all of the studies ongoing at the same time, and Africa CDC is playing a leading role for that. As an example, I will talk, next slide, I will talk about the ongoing study regarding the smallpox vaccine versus the control to confirm, to prevent confirmed cases. And this is one of the studies that our team is conducting in DRC and in Uganda. And we believe that the first semester of 2025, we can get the outcome of the study that will help us to talk about the post-exposure prophylaxis regarding Mpox disease. The next slide is about the vaccine for children between 2 to 12. As you know, Bavarian Nordic, when we started to use that, it was for 17 to 17 plus. Then 12 plus. Then we got approval to use for 7 plus. Now we have the study ongoing to see if we can confirm that based on the approval from SAGE for 2 plus. It means from 2 years to 12 and plus. This study is important for us to convince our communities that this vaccine is safe and we can use that without any issue, and to open the door for the NITAG at country level to give the green light for use of the vaccine. The last slide is just giving you an overview in terms of diagnostics and therapeutics. I think we discussed the qPCR testing kit coming from Morocco. Now we are working on how to decentralize the Mpox diagnostics and also considering the POC, point of care. We have our team led by Professor Mosoka working on a number of clinical trials for therapeutics. As we know, the Covirimat was not the appropriate one for clade 1B. Then we are conducting a number of studies. Just to show you that we are working hard. This outbreak, Mpox, is requesting more funding for all of these researchers for the response. And the good news also is we got from Japan that next week we are getting the Japanese vaccine in DRC that will allow to vaccinate children. It means 0 to 5. And we can then make sure that we can control the outbreak for not only adults, but also the children. Let me stop there and welcome your questions. My brother, Dr. Mwamba, is joining us today. He will be more than happy to respond to any question related to what is happening in Panzi. Over to you, Margaret.
Thank you very much, DG. Let's take the first question. Janice from Bloomberg, you have the floor. Janice, can you hear us? All right, let's take the next one. Carmen from Politico, you have the floor.
Thank you so much, Margaret. I had a question about disease X. The WHO said, I think, that 10 of the cases tested positive for malaria. So I was wondering if you can confirm that. And is there a timeline, given all the difficulties that DG Kasea was outlining, is there a timeline now that you expect to sort of like have a confirmation of what this could be? Last week, we were hoping 48 hours. What's your estimation now that we might know more about this? Thank you.
Thank you so much.
DG.
Do we have Dr. Mwamba online? Dr. Mwamba, are you there? DG? Yes.
Yes, I'm there.
Yeah. Oui, DG, il y a cette question.
Yes.
C'est à vous de répondre, je vais vous comprendre.
Okay, oui, j'ai compris. But I can respond in French.
Yes.
Ok, j'ai suivi la question par rapport aux échantillons. Ce que je peux dire, c'est que les échantillons qui sont arrivés à Kinshasa la semaine passée étaient arrivés dans un état qui n'était pas de bonne qualité. Donc, on a eu des difficultés pour tester les 12 échantillons qui étaient arrivés, mais au niveau de l'INRB, ils ont fait quand même un effort pour essayer de les tester. Et ces 10 échantillons, effectivement, on le dit, étaient positifs. C'est au Plasmodium. Donc, c'était le Plasmodium falciparum. Donc, c'était les paludismes. Et nous sommes à ce stade, au jour d'aujourd'hui, il y a environ 78 échantillons qui ont été, parce qu'on a renvoyé des équipes sur terrain du niveau national avec une forte équipe de l'INRB, donc des virologues, des parasitologues qui sont descendus, qui ont accompagné l'équipe de l'INSP. Donc, on a eu à prélever un grand nombre d'échantillons, autour de 78, et c'est plusieurs types d'échantillons. Donc, nous avons des échantillons de sang, de sel, des urines, et qui sont en train d'être acheminés sur Kinshasa en passant par Kenge. Donc, et nous sommes présentement même en train de voir les possibilités d'envoyer demain un avion qui pourra récupérer ces échantillons à partir de Kaemba pour être à Kinshasa demain en fin de journée. Et espérons avoir les testings et les résultats durant le week-end prochain. Merci.
Thank you, Carmen. I think you understood from the DG. The person who tested the samples is the person I was naming in my presentation, Professor Placide Mbala. I clearly said, because the quality of the samples was so poor, we cannot proceed with what we need to do to confirm. But for malaria, we did the routine test. For us, Africa CDC will not say is malaria. No. As the DG said, we are waiting for the 78 samples to reach Kinshasa. And then when Professor Mbala will test that, we can be able, hopeful, Monday, we can say something. If we are unable to bring these samples by Monday, we'll communicate and we'll say when ideally we're expecting to provide information. Back to you, Margaret.
Thank you, DG. Let's take the next question. Nemin Osman, you have the floor. Nemin, can you hear us? All right, let's take the next one. Esther Nakazi, you have the floor.
Thank you very much, Margaret, and thank you very much, DG. I've got two questions. One of them is, what is the likelihood that this disease X might come to our countries? I'm based in Uganda. Is there any efforts that you're doing to stop or even train our own people to understand or to contain it? And then number two, we do have children who are also suffering from Mpox. Are we getting, other countries getting Mpox donations of vaccines from Japan, like DRC? Thank you very much.
Thank you. Over to you, DG.
Thank you. Quickly, Esther, on the Mpox vaccine for children, Africa started already to advocate to Japan to see if we can have additional doses for other countries. As you know, these 3 million doses donated to DRC came from the stockpile, the Japanese stockpile. And we are negotiating with them, and we'll see what will be the outcome. But they were open for that. From our side, it's clear. All Africans, they have the same right, and we'll do our best to make sure that all children, all adults who need vaccine, they will be vaccinated. Regarding the possibility to see the disease X spreading to other countries, including Uganda, I cannot comment on that for now because I don't know what is it, this disease. And I don't want also to give information that is not correct because I will name this disease when I will get the result from the laboratory. Then from there, we can say, what is it? What could be the mode of transmission? What could be the likely spreading process? And all of that we communicate. But for now, we cannot say anything. We just know that we are doing our best to support. And I want to thank and to congratulate the government of DRC. I know the minister and Dr. Mwamba, they are doing our best to make sure that we know this disease very quickly. Over to you, Margaret. Then maybe Dr. Mwamba will provide additional comments if we have other questions.
Thank you very much. Let's move on to the next question. Gabriel Emmanuel, you're welcome. You have the floor.
Hi there. Thank you very much. My question is about the arrival of the pediatric Mpox vaccine that you mentioned next week. I wanted to find out, it sounds like it's going to arrive in country, but could you tell me a little bit more about the rollout of when it will make it to children and kind of what's needed for that rollout to happen, including, I know it has a different bifurcated needle, things like that. In terms of disease X, I was actually wondering if you could describe a little bit what Ponzi is like in terms of the environment and the conditions the team there is working in. Thank you very much.
Thank you, DG. Let's take the first one and then we'll move to the director for the second question.
Yes, even for the first one, the director can respond because
yes,
is not there for disease X, is there for all disease. Director for the rollout of the Japanese vaccine, then I will complement you. Over to you, Director, for the question on Japanese vaccine and Ponzi.
Thank you, DJ. En rapport avec le vaccin japonais, effectivement, nous sommes en train d'attendre ces doses de vaccin pour la semaine prochaine qui pourront arriver et nous avons une délégation qui va arriver ce week-end du Japon, effectivement pour procéder au training, à la formation, parce que on sait que ça nécessite des aiguilles bifurquées pour faire la vaccination avec le vaccin LC16. Et nous avons programmé pour la semaine prochaine cette formation des prestataires qui vont utiliser ce vaccin-là. Donc, c'est prévu que nous ayons, qu'il y ait une formation des prestataires pour la manipulation et l'utilisation de ces aiguilles bifurquées parce que c'est quand même une technique pour laquelle qui n'est pas d'usage courante dans notre vaccination de routine. Donc ça, c'est prévu avec les équipes du Japon qui vont arriver ce week-end en RDC. Concernant Ponzi, si j'ai bien compris la question, c'est que on demande un peu l'environnement. Ponzi, il faut savoir que c'est une zone de santé qui est très enclavée. Et dans la province du Kwango, c'est à 470 km du chef-lieu du Kwango. Et la route n'est pas assez facile. Les équipes prennent 2 jours partant du chef-lieu de Kwango pour arriver à Ponzi. Donc, c'est une zone d'accès très difficile. Et il n'y a pas de réseau de communication. Donc, c'est une zone, quand vous êtes là, même les équipes qui sont là, on a des fois du mal à communiquer avec elles parce que ce n'est pas une zone qui est vraiment couverte. Et c'est ça aussi même la difficulté que nous avons pour l'acheminement même des échantillons sur Kinshasa. Et voilà un peu l'environnement et la situation par rapport à la zone de santé de Ponzi. Voilà, à vous.
Thank you. Thank you so much. When the director is talking, for those who want to understand what was my starting in the public health area, I was medical doctor and leading the medical district neighbor to Panzi. We didn't have network, we didn't have roads. It's exactly the same after almost 25 years. It means colleagues who are there, we need to support them because they are working in a very difficult environment. And we hope we can know what is going on and have with the government a clear plan to support this region. Over to you, Margaret.
Thank you, DG. Let's take the next one from the chat box. This one is about Mpox. So the question is, how is the government managing efforts to curb the spread of Mpox in affected member states, and how effective have these measures been so far? That's the first question. The second one is, are there plans to scale up vaccination or other preventive strategies for Mpox across Africa? This is from Edward Samuel of the Voice of Nigeria. DG, over to you.
Yes, I think it's almost the same question, but let me say we have meetings every week with all countries at IMST level. They are talking with all director generals of NPHIs and key people in the Ministry of Health of affected countries and at-risk countries. We are sharing information openly, transparently with everyone, and we are building capacities. We are providing support for surveillance, for laboratory. And if you see previous slides, I was showing how mostly all countries, they have 100% capacity to test Mpox. We have issues in DRC, in Congo-Brazza. But DRC, it's due to the huge increase of cases and our investment didn't follow. We are doing our best to see with our member state and partners how we can achieve that. And by doing so, we are also helping with the vaccination side to stop the transmission of the disease. As you saw in my presentation, we are doing a kind of screening and supporting at point of entry. We have a number of actions we are conducting that can help to stop the spreading of Mpox. To be clear, for us today, we need first to have a strong surveillance mechanism in all African countries. Second, we need to have a strong lab network, decentralized in all African countries. Third, we need to have capacitated human resources. And fourth, we need to have all tools, it means vaccines and medicines. If we have all of that, we can stop quickly the outbreak. Otherwise, it will become a major challenge for us.
Thank you. Let's take the next question. Janice from Bloomberg, you have the floor.
Oh, thank you so much for coming back to me. You can hear me this time.
Yes, we can hear you.
Great. Thank you. My question was really around the sample quality. Understandably, the first lot were tricky, but equally from last week, I'd understood that to really get good samples, you also need to get to the point of testing them within 2 days. And from what I'm hearing again today, you know, that the difficulties of terrain, even if they've flown for the last leg of the trip, it's pushing them probably beyond that 2-day period. So I was just wondering on what hopes you have for really decent quality of these samples, considering that time delay. And my second question is probably quite left field, but I was really just wondering if there's any chance that this particular population, being fairly remote, has not previously been exposed to COVID-19. I saw from the WHO that that was one of the list of things that they were considering, and I just wondered if that was something that they might possibly not have been exposed to previously.
Thank you, Janice. There will be so many people saying so many things. But as we say, Pansy is the mirror of the health system in DRC, mostly in the rural area. Today, the president, the discussion I had with the president and the minister, they are clearly telling me that they have a program, they call it 145 district, that will help to rebuild the health system at rural level. And I proposed the support from Africa CDC to see how we can implement quickly this program. We cannot achieve what we want to achieve if we don't decentralize the lab system. You can imagine Pansy, that is a region where you have more than 200,000 people without lab capacity. If they have to send samples, as the Director General was saying, using either Kikwit or Kenge, Kenge is the capital of this region, they have to take 2 days from Pansy to Kenge and 1 day from Kenge to Kinshasa. What will be the quality of this sample if we don't take appropriate action? For us, we are working with the government to put the capacity to all health districts, including Pansy, to all now. The qPCR will not be done in Kinshasa, but it will be done in Kenge, the capital. But for this specific disease, we need even to do the genomic sequencing and everything. This is why we are bringing the sample to Kinshasa, because we don't want to miss anything. Regarding the exposition to COVID or not, you know, as I said, we are not here to spread rumors. We are here, we are led by science. We are waiting for the result of the sample. For all journalists, the message from DSC and from Africa CDC is clear. There is no confirmation of the pathogen. We are waiting for next week, then we'll communicate. If it will be malaria or another disease, we'll make it. Then from there, we'll take appropriate action. Directeur général, je ne sais pas si vous voulez compléter à la question de Janice.
Non, merci DG, mais je pense que vous avez bien résumé. En fait, jusqu'à maintenant, nous attendons vraiment la confirmation laboratoire pour savoir vraiment de quoi il s'agit. Donc, le diagnostic est vraiment attendu. Donc, c'est pourquoi il ne faut pas, comme vous l'avez dit, prêter flanc aux rumeurs et laisser distiller des rumeurs. Donc, au niveau du ministère, nous sommes vraiment... c'est pourquoi nous mettons tout l'effort pour acheminer les échantillons malgré les conditions difficiles au niveau de laboratoire de l'INRB pour arriver à poser le diagnostic et de là avoir une conduite appropriée pour organiser la riposte et arriver à renforcer le système de santé, comme vous l'avez dit. Donc, parce que cette zone de santé est vraiment une image de la situation de nos zones de santé, surtout en milieu rural et reculé. Voilà.
Back to you, Margaret.
Thank you. Let's take the next question. This is about Mpox. Can early antiviral treatment improve Mpox outcomes in immunocompromised patients, particularly those with HIV and AIDS? That's the first question. The second one is, what is the efficacy and safety profile of existing Mpox vaccines in African populations with high HIV prevalence.
So shall
DG?
I continue till the end?
Yes.
Okay. Namin, if you can hear us. DG, I think let's take those two questions and then we'll come back to Namin.
These two questions were from Nermin?
No, they're from the chat box.
Okay, I lost you a few minutes. I think I got the second question about the safety, but can you please repeat because Nermin was talking at the same time.
All right. So can early antiviral treatment improve Mpox outcomes in immunocompromised patients, particularly those with HIV and AIDS? That was the first one. The second one is about the efficacy and safety profile of existing Mpox vaccines in African populations with high HIV prevalence.
Thank you. This is a subject of research that Professor Mosoka is conducting. Chanel, are you with Mosoka to provide answers to these two questions? Over to you, IMST.
Thank you very much, DG. In terms of treatment for antiviral, as you know, the only available therapeutic trial we had was a tacrolimus that's proven not to be effective against treatment. So we have no antiviral now in terms of the therapeutic. We're working on the branzidovec trial that we are going to begin recruitment in December, and HIV will be some of the population we target. Most of the MVA vaccines that have been used have included HIV, has not shown any side effect among them. So in terms of the population, they are targeted as special population of interest, including high-risk sexual workers, and they have not shown any safety or efficacy issue. We reviewed some data, especially in Rwanda, where they didn't see any unusual adverse effects. But in terms of antiviral treatment, none exists now. We'll be able to know answers in about 2 or 3 months when we launch the branzidovec trial in December. Thank you.
Over to you, Margaret. Thank you, Professor Mosoka.
Namin, if you can hear us, you can come in. Namin, can you hear us?
I can hear you. Can you hear me?
Yes, we can hear you. Go ahead.
Thank you very much. My questions was already answered. Thank you.
Thank you.
All right, thank you. Let's move on to Ida from South Africa. You have the floor.
Thank you very much. Dr. Kaseya and Margaret, can you hear me?
Yes, we can hear you.
Thank you.
Wonderful. Could you please talk a little bit about the term disease X, which was, as you I think hinted earlier, was so quickly used in the media, and I don't know where this originated. But I mean, given that the nomenclature or the term disease X in our minds has been reserved for an yet undefined pathogen, a new pathogen, and given that we do not yet know what this pathogen is, what illness those people have, is it not perhaps unfortunate that the term disease X is now being so widely used? And what are your views on that? Thank you.
DG.
Thank you. DG, à vous.
Oui, merci pour la question. Bon, on demande pourquoi on parle de la maladie. Effectivement, on n'a pas encore la cause, le diagnostic pour cette maladie. C'est pourquoi on peut l'appeler, nous l'appelons la maladie d'origine inconnue, d'étiologie inconnue, jusque-là. Mais les signes que la plupart des malades présentent, parce que l'équipe qui est sur terrain, qui essaie de faire des investigations, et voir quels sont les signes que présente la majorité des malades. C'est que le tableau clinique, il est fait c'est la fièvre, principalement, les céphalées, accompagnés de rhinorrhée et de toux. et deux fois, on a des difficultés respiratoires qui apparaissent. Donc, voilà les principaux symptômes qui sont présentés par les patients. Mais je l'avais dit aussi la dernière fois, c'est que cette zone de santé, c'est sur un terrain vraiment d'une forte malnutrition. Donc, c'est un terrain où il y a la population, c'est une forte malnutrition qui est notée, surtout chez les enfants de moins de 5 ans. Et c'est surtout parmi les patients, plus ou moins plus de 40% de ces patients sont les enfants de moins de 5 ans. Donc, voilà un peu la symptomatologie, les signes, les principaux symptômes qui sont représentés par les patients atteints de cette affection. Merci.
Merci. Juste pour, merci DG. Ida, just to be clear, DRC,
Thank you.
DRC, they are not using disease X. They are using febrile illness of unknown etiology. I think
Okay.
even ourselves to be aligned with DRC, Africa CDC will no longer use disease X, will start to use febrile illness of unknown etiology till when we'll get the confirmation. Thank you.
Wonderful. Thank you so much for that. Thank you.
Back to you, Margaret.
Thank you, DG. The next question is on Mpox. So since the launch of the Mpox vaccination in DRC, how has the epidemiological curve evolved in relation to new cases?
DG, à vous, puisque vous dirigez aussi Mpox en RDC.
OK. Par rapport à Mpox, parce que la question est en rapport avec la courbe épidémique, au cours des 3 dernières semaines, nous constatons une légère tendance à la baisse au niveau de notre courbe épidémique. Et pour donner un exemple, bien qu'un nombre absolu de cas, si je peux, nous sommes autour de 53 860 cas notifiés. Mais quand on regarde par semaine le nombre de cas, la semaine 48, nous étions à 487 cas qui étaient notifiés. À la semaine 49, nous avons eu 604 cas, donc une légère augmentation. Mais quand on regarde de façon globale, la courbe, nous notons une tendance légère à la baisse. Mais il y a des provinces quand même où les nombres de cas continuent à augmenter. Dans certaines provinces comme au sud Kivu, nous notons toujours que dans cette province-là, et nord Kivu, la tendance demeure quand même toujours à la hausse. Voilà.
Merci, DG. We have Dr. Doud, who's working on the vaccination pillar. And the question was, how can we assess the impact of the vaccination in the region where we already vaccinated vis-a-vis new cases of Mpox? Dr. Doud, can you please provide additional information to complement what the DG said, but mostly focusing on regions where the vaccination already started?
Thank you, DG, so much for the floor. The vaccination is ongoing in Kinshasa. It's been going on for a few weeks now. There's a big focus on the biggest area is Pakajuma, where we've seen a concentration of Mpox cases. We were there last week with you, and we can report that the vaccination will commence daily now. It was initially only for 2 days, but now we'll have teams vaccinate every day in the field, which we should see should have an increase in terms of the numbers of kids vaccinated, individuals vaccinated as a result of the new strategy of going daily as opposed to only going twice a week. So that should be a major impact. And then we'll expand to additional health zones in the next coming weeks. That's the planning from our side. Thank you.
Thank you so much. Back to you, Margaret.
Thank you, DG. And with that, we have come to the end of the weekly briefing this week. I will now hand it over to you for your closing remarks.
Thank you so much. The first one is about next week, Rwanda officially will declare end of Marburg. I want all of us to be there, and the minister will give us the overview and the lesson learned from Marburg in Rwanda. That one will be on Thursday, our regular Thursday press conference. The second one is about the febrile illness of unknown etiology. In the past, we are calling that disease X. We know that every week there is an increase of cases. As I was sharing with you, we saw this increase last week, and we are waiting for the samples to reach Kinshasa. As the DG said, we hope with all effort from the government and partners, we can have the samples by Monday and communicate with you. If there is a delay, the DG will be with us on Thursday. He will be the person officially giving the information to the media about the disease. I want also to say that Mpox is still a major issue. Now we are facing challenges in terms of resources. We are calling our partners who pledged funding to understand that it's time for them to disburse. We need to support more and more countries. Now we see the case in Angola, and it will continue like that if we don't have resources. This is why, if journalists can help us to make this message loud, vocal, we are calling all of them to provide appropriate support. Mpox for me is the entry point to strengthen the surveillance and the lab. If we did great job for Mpox, if we did great job for COVID, today will not face the same challenge for this disease in Panzi. I think we are learning from all of that, and we hope we'll continue to improve. With that, I thank all of you. Let us meet next week with some good news, like from Rwanda, and also with a major update from DRC. And we hope to provide additional update regarding vaccine, the Japanese vaccine, the rollout of this vaccine, and also the vaccination in other countries. Thank you so much, and see you next week.